Thank you. Good afternoon, everyone, and welcome to our webinar series. For more than a year now, we have initiated this webinar series where we have been trying to address local and regional level treatment therapy needs, some challenges and opportunities with the help of speakers who are subject matter experts across different countries and continents. I am Dr. Rahul Mandlik. Welcome you all on behalf of Shalina Healthcare to this 14th webinar in this series, which is focused on enhancing the surgical outcomes. So with me today we have eminent speakers from India and Nigeria who are going to talk about the best practices and the management of typhoid enteritis and enteric perforation as well as post-surgical or surgical site infections management. So we all know that surgery as a field has immensely contributed to medical field, and surgery field as such is undergoing through many changes, and it is continuously evolving with many advancements. That is why any healthcare practitioner in this area needs to keep themselves updated and upgraded with new techniques and skills. That is how we have focused on today's webinar with this topic of optimizing surgical outcomes with the help of some surgical videos. Well, very briefly about Shalina Healthcare. Today, we are one of the largest pharmaceutical companies in Sub-Saharan Africa, and from last 35 years, we have made it our mission of manufacturing quality medicinal products which are available across Africa at affordable prices. And we achieve this by manufacturing our product at our own WHO approved facilities, and we are also involved in complete bandwidth of social activities. So without any further delay, let me welcome our eminent speakers for today's webinar. Dr. Roy Patankar, who is a consultant gastrointestinal and laparoscopic surgeon and director of surgical services at Jain Multispecialty Hospital, Mumbai, India. He is also an international surgical advisor at Royal College of Surgeons of Edinburgh, and he is an executive committee member of governing council at Association of Surgeons of India. Dr. Patankar is currently a treasurer of Association of Colon and Rectal Surgeons of India, and he is an EC member of Association of Minimal Access Surgeons of India. Dr. Patankar has conducted more than 40 such workshops. He has performed more than 850 Nissan's fundoplications, and he is pioneering technique of using narrow band imaging and chromendoscopy techniques. Dr. Patankar has presented more than 100 papers in national and international conferences. He has delivered more than 150 guest lectures and published more than 40 articles in national and international journals. Welcome, Dr. Patankar. And Dr. Abubakar Bala Muhammad, who is a consultant general surgeon and postgraduate coordinator of residency in surgery at Aminu Kano Teaching Hospital, that is AKTH from Nigeria. Dr. Bala is a secretary of academic committee of surgery department at AKTH, and he is a peer reviewer of the West African Journal of Medicine. He is a principal investigator for Argo researches going on at AKTH, and he is involved in many landmark clinical trials like African Surgical Outcome Study, Falcon Trial, COVID Surge Study, and Talon Trial. He has played a very important role in designing ASOS surgical risk calculator, and he has published many articles in national and international journals. I welcome Dr. Abubakar Mohammed. So while attending this webinar audience, you can post your questions and feedbacks in the box provided to you, which will be taken up during Q&A session after the end of session from both the speakers. So flow of the program is now I invite Dr. Patankar to deliver his session. Followed by that, Dr. Abubekar will take us through the post-surgical site infection management, and then we will move to Q&A session. Over to you, Dr. Patankar. Thank you.
Dr. Patang, I think you have stopped the screen sharing. Yes, please.
Can you hear my audio and video clearly?
Yes.
Is my audio and video clear to you?
Yes, sir. It's
Great. Good evening, ladies and gentlemen, or maybe good afternoon in Africa. It is my proud privilege to be talking to you this evening on typhoid enteritis and surgical sepsis, two very common topics that all of us as general surgeons or GI surgeons face in our day-to-day practice. What I've attempted to do is talk to you a little bit about surgical practice and some burning issues which I think need to be addressed, such as enterocutaneous fistulas, the use of drains, the use of antibiotics, and broad principles governing surgical sepsis. I'd like to thank Shalina Healthcare and, of course, Talkmore Technologies for their role in bringing us all together in these rather difficult times. I'm sure the African continent is as badly hit as the Indian subcontinent in COVID, and a lot of our thinking patterns have changed. And it's not only the Darwinian theory of the strongest or the most intelligent that will survive, but that species, those surgeons that can manage change, is those who will survive and flourish. So when you look at surgical sepsis, surgery has a definite role, but there is more to it than just surgery. I've looked at some papers which I will quote here. This is in the World Journal of Emergency Surgery, and I know this is going to be recorded for the youngsters, the residents, the junior surgeons in the audience. I'd like you to go through these papers which I've used. This is a very recent journal, January of 2021. Coming on to enteric fever, this is an African publication on enteric perforation and something about prognostic factors from the East African Medical Journal. A paper about typhoid ileal perforation in children, and overall in the Journal of Infectious Diseases in 2020 December, looking at complications and mortality of typhoid fever. I'm going to base a large part of the principles of my talk on something called Surviving Sepsis Guidelines. This was published in Intensive Care Medicine in January of 2017 and is an outstanding paper which I would advise all of you to go through and should form the bulwark of your post-operative or pre-operative management of sepsis or surgical shock. What I'm going to tell you in the next 20 minutes is largely based on Surviving Sepsis Guidelines and also based on our experiences of managing surgical sepsis in the last 25 years. I worked in the UK for 7 years, in the United States for 2 years, and then in India now for 20 years. Remember, bacterial infections are most common, though fungal, parasitic, or viral infections can also cause problems. The risk is due to the host factors: elderly people, genetic predisposition, the comorbidities like diabetes, blood pressure, ischemic heart disease, patients who are immune suppressed, HIV, steroids, and the elderly account for a significant proportion of patients with severe sepsis. Also remember that we are a tertiary care center in Mumbai, which is on the west coast of India. So a lot of patients who are come to us with enteric problems or surgical sepsis often come on 4, 5, 10 days post-operatively. They have central lines, they have PICC catheters, they have dialysis catheters, they have Foley's catheters. So invasive devices and secondary infections do cause a lot of change. And we have seen a fulminant rise in the number of fungal infections associated with central lines and sepsis. Whenever a patient undergoes sepsis, he has to go through these 5 roles. The SIRS as the systemic inflammatory response syndrome, When you have infection joining it, it's sepsis. When you have end organ damage, it's severe sepsis, then severe shock, septic shock, and finally multi-organ dysfunction. When do you call it SIR? And remember, SIRS is not infection. This is that something that happens in the immediate post-op period and is the body's inflammatory response to inflammation. So either you can have hypothermia or hypothermia. You will have a tachycardia, a leukocytosis, but remember you may also have a leukopenia and a tachypnea and a fall in PCO2. When you have sepsis plus new organ dysfunction, be it hematological, cardiovascular, renal, metabolic, respiratory, or neurologic, then we call it severe sepsis. Septic shock is basically linked to cytokine release, secondary to a large-scale inflammatory response leading to vasodilation, increased capillary permeability, microclots happening, hypotension causing poor tissue perfusion and tissue hypoxia. And eventually you get multiple organ dysfunction syndrome, which has a very high mortality. It can be any of these three organs that I have mentioned here. Now I'm going to point you to some very practical things, and this is what we teach. We have a postgraduate training program in our department, and we have a super specialty program in GI surgery. We teach them this treatment bundle, and I'm going to talk about this as we go on. Lactates, blood cultures, antibiotics, fluid resuscitation, and reperfusion assessment. Extremely important to take aerobic blood culture prior to starting antibiotics. We will do this in our emergency room, in our casualty. Before the patient is given a shot of IV antibiotic, his blood culture is collected, and then based on our organizational bacteriogram, antibiotics are started. Clearly, early antibiotic initiation is important because delay increases the risk of mortality by 4 to 8%. Our policy in any peritonitis is to use cefoperazone sulbactam immediately after drawing the blood culture. Why this antibiotic? This is based every month we audit the infections that we are getting, the antibiograms, what organisms we are seeing in our intra-abdominal sepsis, and what antibiotics the bugs are resistant to. This is extremely important. So very important that do not delay antibiotics. The Society of Critical Care Medicine recommends the use of ringer lactate or normal saline. So never start blood, never give plasma, never give gel fusion, start with crystalloids. Important to give a fluid bolus based on their cardiovascular system. You have an ischemic heart disease, depressed ejection fraction, be careful of loading the patient without a central line. Extremely important to look at the lactate level. Lactate to me is one of the best markers that we see in patients with surgical sepsis. Basically, it is an index of tissue perfusion. If your lactate remains high for more than 6 hours, I will guarantee you the mortality levels are very high. If lactate more than 4, more than 25%, 1 in 4 patients are going to die. I call this a Sepsis One Bundle. Look at your patient carefully. Is there a provider documentation of suspected infection? Does he or she have 2 of the last 6 SIRS criteria? And is there organ dysfunction? Look at draw lactates, draw blood cultures, administer broad spectrum antibiotics, and give fluid resus as 30 ml per kg of crystallite. And our preference is to use ringer lactate in these patients. If a patient has septic shock, then as per the surviving sepsis guidelines, we will start a peripheral dose of noradrenaline. This is again extremely important. Early use of noradrenaline will reduce end organ damage. Very important to assess perfusion as well as tissue perfusion. Look at all these carefully, and these are very simple things. Look at the arterial oxygen, look at the vital signs, look at capillary refill, look at the fingertips. If you're a resident or a young student, please look at the patient's fingertips. Is there a good capillary refill? Is it cold and clammy? Is the capillary refill poor? You don't often need fancy things. You need a brain between your ears and you need to think carefully. Look at the urine output. The second stage is once he's in the intensive care unit, look at the central venous pressure. You may do a bedside 2D echo. Look at the result of passive leg range and then look at the tissue perfusion statement. There's an interesting study from the Society of Critical Care Medicine which published a retrospective cohort study. And they say that when these initial bundles were delayed, the in-hospital mortality was 27.8%. Lactates, blood culture, antibiotics, and crystalloids, very, very simple. In the emergency room, drop a blood culture, check his lactate level, give a dose of antibiotics, and infuse crystalloids, as I said, either normal saline or ringer lactate. Remember, think clinically. As a resident or a young surgeon looking at a patient in the emergency, look at the capillary refill, look at his mental status, look at his tissue perfusion, look at urine output before taking him to the ICU. And this is basically to decide which patient can go to the ward and which patient should go to the intensive care unit. This is extremely important. Now, these are 4 videos which I'm going to show you. We do a lot of advanced laparoscopic surgery in our hospital, and the majority of perforations that we see, whether duodenal perforation, ileal perforation, colonic perforation, are managed laparoscopically. The top left and the top right are bad ileal perforations with extensive contamination. You can see the ileal perforation beautifully seen in the terminal ileum. You can see inflamed terminal ileum. This is typhoid enteritis, and this is extremely, extremely important. Remember, severe sepsis. What I'm doing on the right top video is to take a biopsy of the edge because the edge was necrotic. I also want to confirm that this is enteric fever. Like in Africa, we also see tuberculosis, so we want to look for any strictures next to it. So what we do is freshen the edges, and then you can see me suturing this, and I'm using an ordinary 2-0 Mersilk and 2-0 Vicryl in both these sutures. Remember, severe contamination, bad peritonitis is not a contraindication to laparoscopic surgery. We will, in our hospital, we will do lap surgery in almost all patients of perforations unless there is a technical issue. You see a fairly large perforation on the top left-hand video, almost 1 centimeter in size. I have excised the edge for biopsy. That also helps the edge to get freshened up. And then I'm using, what I do is I don't tie off the sutures. This is a little technical point for the young surgeons. Once you tie it, you don't see the mucosa well. So what I've done is I've taken 3 sutures along the long axis of the intestine. 2 sutures are with Mersilk, the first and third, and the middle is with Vicryl. So it's of a different color. And then once all the 3 sutures are put, I have good bites of all of them, then I'm tying these sutures at the same time. So this gives me a good closure. You can do this in 2 layers if you wish, and you may decide to put in an omental patch if you so feel appropriate. So these are how basically these perforations are done, and I'll run through this video just to show you how it is done. And this is the second layer that is being done on the top right-hand video. When the bowel was, if it's a very bad one, then it is better to exteriorize the bowel and do a ileostomy. Whenever I feel that the bowel is healthy, I will do a 2-stage suturing like you see me doing here in these patients, and the morbidity and the leak rates are very low with this technique. What you need to do is assess whether the bowel is healthy, it is well vascularized. If it isn't, then I would suggest doing exteriorizing the bowel to do a lobe lapstoma. Should we do lap or open surgery? Clearly, you need to decide based on what you are comfortable with. But if you are good, if you have, see, this is a severe peritonitis, patient on septic shock, we will always do this laparoscopically, and the kind of wash you can give with laparoscopy is as good as you can give with open surgery. What we are concerned about is there a issue of mesenteric ischemia? This was a gangrenous bowel. The CT had not shown us this. Patient had come from a peripheral hospital, traveling 12 hours by ambulance, and he actually had a mesenteric ischemia. So this is very important that you rule this out. This, ladies and gentlemen, is something called the Dunning-Kruger Effect. When you start off in surgical practice, you're fresh out of residency, you've passed your postgraduate examination, you think you know it all. You can tackle any perforation that comes your way. Then you start getting some morbidity and complication. Then you think, my God, there is more to this than I thought. As time progresses, you see some complications. You may have a mortality, and then as you get gray hair like mine, you realize that surgical sepsis can be a complicated topic. So this is true for most things. Now, when you do an anastomosis, whether an ileal perforation closure or an anastomosis, the biggest fear in our minds is of anastomotic leakage. Remember, your drain may be fallacious. Your drain may be dry. Look at the patient clinically. A patient on day 3 or day 4 who has a tachycardia, who has a tachypnea, who has raised WBC count, an increasing CRP level, who's breathless, who's slightly obtunded mentally, please do not go by a dry drain. I tell my residents is your hand should be on the pulse and the other hand should be in the abdomen. If you're in doubt, get an early contrast enhanced CT scan. Enteric perforations can be bad, the bowel can be inflamed, and you can have controlled leaks. Remember, if there is no intra-abdominal collection, there is distal continuity, then usually conservative management will be okay. If you have a high output fistula, say more than 500 ml of ileal content in your drain, better to go in early, re-explore the patient, and do a damage control. On the other hand, if it's a localized sepsis, a pelvic abscess, a subphrenic abscess, then a CT-guided pigtail is good enough. What is the principle of damage control surgery? We often get referred patients from peripheral, smaller rural hospitals, patients who are sick, who are in septic shock, who are in SIRS, where there is gross peritonitis. At this status, don't look at how bad the patient is. Obviously, they'll be very sick. They will be very high risk. You'll take all medical legal precautions that are in, and we'll temporarily go in, but go in and drain. Remember, source control. Antibiotics do not take care of sepsis if you don't take care of source control. For the youngsters in the audience, for the residents in the audience, source control must go with antibiotics. Remember, sepsis is not an antibiotic deficiency syndrome. Hitting a patient with 2 broad spectrum antibiotics and antifungal and metronidazole doesn't compensate for doing surgical toilet. This is a Bogota's bag, what we use. This is actually, I use a urine bag. In a very poor patient who can't afford a laparoscopy and a mesh, I will just suture an abdominal bag on this and go in for a second look laparotomy. Beware of this kind of bowel. You see patchy areas of ischemia. So this is a patient post-COVID, and we see a lot of patients post-COVID who come with mesenteric ischemia. You will need to do a diagnostic laparoscopy and a relook laparoscopy at 48 to 72 hours because the mesenteric ischemia often worsens. These are various patients who have been referred to us from outside, patients who are sick, who are in SIRS, and it is important to emphasize that source control. Go in quickly, at least drain out the pus, leave the wounds open, do a laparostomy, do a Bogota's bag closure, do a mesh enhanced closure, but drain the sepsis. Simply using antibiotics for sepsis is not good enough. And we have a large series of such patients because we get referred a lot of these patients from the periphery. To quote the words of Michael Johnson, ladies and gentlemen, I have failed time and over again, and that is why I succeed. There are enteric perforations where sometimes when the bowel is very unhealthy, we tend to exteriorize the bowel, bring out the perforation as a stoma. It is better to do a second stage surgery rather than having a leaked anastomosis, because in a sick patient who is in gram-negative sepsis, an intra-abdominal leakage is going to cause mortality. So this is a valid option which can be a damage control surgery. What about drains? Do use drains, but use them judiciously. Remember, think about what kind of drain material you expect to get. If it's you expect a dew perforation and bile, you can put a Jackson Pratt drain. You expect a colonic leak or ileal leak, then use a tube drain. To quote my favorite author, Moshe Shine, professor of surgery from New York, abdominal drains are clearly the subject of controversy, practiced in confusion, and subject to local dogmas. This is a patient who came to us with from a peripheral hospital in Western Maharashtra, about 200 miles from where we are. Where you can see the ileal perf, and when I did a colonoscopy, we can see a tube drain perforating through the sutured perforation, and this is not uncommon using Malikot's drains. The last part of my talk on typhoid enteritis, as well as surgical sepsis, is on enterocutaneous fistulas. An unhappy situation, but you and I will face this when you handle really sick people. Stabilize the patient, resusc him well, look at the nutrition carefully. The serum albumin remains an important prognostic marker. Remember, clinically, albumin takes 14 to 21 days to go down. So a patient who's come to you on day 7 or day 9 or day 10 may have a fallaciously high albumin level. Take care of it. Do a early contrast enhanced CT, do source control. Either pigtail the collection, do a laparotomy, do damage control surgery, do a laparoscopy. Optimize the wound management. Many times, because of ventricular fistula, the skin tends to get digested. Use wound managers. Use stoma adhesive paste. If you have a poor patient, I suture a urine bag on this, and get in an interventional radiologist also in this. So I've tried to minimize my talk to 30 minutes as I was asked to. I've tried to give you an overview on the concepts of surgical sepsis and enteric perforation. I'll be happy to expand this if you have any queries on this. Thank you very much. I now hand over the mic to Dr. Bala for his next presentation, please.
I hope you can see my screen. Can you see my screen?
Yes, doctor, we are able to see your screen. Please put it to slideshow mode now. Yeah, let's begin.
Okay, thank you very much. Good afternoon, everyone from Kano, Nigeria. I am Dr. Abubakar Bala Muhammad. I'm a consultant general surgeon, head of training, surgery department at Mini Kano Teaching Hospital. I'm going to discuss on the management of surgical site infection based on this outline from introduction to conclusion. Surgical site infection is defined as presence of pain at a surgically created wound, which is often accompanied by erythema, induration, and local tenderness, or presence of purulent discharge at wound site occurring within 30 days of the procedure or 90 days if prosthetic material is implanted during the surgery. Although there is no worldwide data for surgical site infection, in the United States of America, it accounted for 2.8% of all infection, according to the United States Center for Disease Control and Prevention. In Nigeria, in a study by Olowokere et al. In 2019, the cumulative incidence of surgical site infection was found to be 14.5%. But it is very important we look at the prevalence of extended spectrum beta-lactam producing organisms. In Europe, we can see, especially Escherichia coli, Klebsiella incidence is rising. So also in United States of America. In Nigeria, it is becoming a problem for the surgeons. For example, it was found that in the hospital setting, extended spectrum beta-lactams accounted to 27.5% of infections. In Kano, it was found to account for 37 out of 747 isolates that were obtained. In a study in Ebonyi State University, 38 out of 105 clinical isolates of Klebsiella pneumoniae were positive for extended spectrum beta-lactam production, lactamase production. Surgical site infection are caused by the deposition of and multiplication of microorganisms in the surgical site of a susceptible host. but this depends on the host's immune response. Therefore, there are a number of ways microorganisms colonize and cause infection. These include direct contacts, either from another patient, transfer from surgical equipment, or the hands of the hospital staff. Airborne dispersal, that is from surrounding air contaminated with microorganisms that were deposited on the wound. Self-contamination, also known as endogenous infection, either physical migration of the patient's own normal flora, which are present on the skin, mucous membrane, or gastrointestinal tract. Most surgical infection is due to bacteria and more rarely fungal infection. The common organisms associated with surgical infection include, in our environment, include Staphylococcus aureus. But we should also note the extended spectrum beta-lactams like E. coli, Pseudomonas, Proteus, as well as Klebsiella. They form a major chunk of the organisms. Still talking about extended spectrum beta-lactamase organisms, the persistent exposure of bacterial strains to a multitude of beta-lactams has induced a dynamic and continuous production and mutation of beta-lactamases in these bacteria, expanding their activity even against the newly developed beta-lactam antibiotics. As ESBLs is beta-lactamase that has the ability to break down commonly used antibiotics. Therefore, extended spectrum beta-lactamase organism is a growing concern for surgical practice worldwide, including our own environment. Based on classification, surgical site infections are classified as either incisional or organ space. Incisional is further classified as superficial or deep. Superficial surgical site infection only affect the skin as well as subcutaneous tissues, while the deep incisional surgical site infection involve the deeper tissues, the fascia, as well as the muscles. In organ space infections include infections that involve any anatomical structure that were opened or manipulated during the surgical procedure. They occur within the body cavity, like, for example, intra-abdominal, intrapleural, intracranial, and directly related to a surgical procedure. These deep infections may occur or may be manifested with few symptoms, mimicking incisional surgical site infections and leading to inadequate initial treatment. They become apparent only when a major complication ensues. The diagnosis of organ or space surgical site infections are usually requires some form of imaging to confirm the site and extent of infection. Also, surgical wounds are classified based on degree of infectivity from clean, contaminated, and dirty wound. We should note that contaminated and dirty wound high rate of infectivity, 15 to 20% for contaminated and up to 40% for dirty. What are the risk factors for developing surgical site infection? Extreme of ages, immunosuppression, obesity, diabetes mellitus, chronic inflammatory processes, malnutrition, smoking, extensive use of steroids, renal failure, peripheral vascular disease, postoperative anemia, prior site irradiation, chronic skin diseases in the area of infection, especially psoriasis, skin or nasal carriage of staphylococcus, recent infection, operation, remote infection. Then local factors. Open surgeries generally are more associated with infection compared to laparoscopic surgery, as highlighted by my colleague in India. Poor skin preparation, contamination of instruments, inadequate antibiotic prophylaxis, prolonged procedures, and local tissue necrosis due to tension. Other local factors include blood transfusion, hypoxia, as well as hypothermia. The microbial factors include prolonged pre-operative hospitalization, toxin secretion, resistance to clearance, especially to a capsule formation, is as seen, for example, in patients infection with extended spectrum beta-lactamase producing organisms. How do we treat surgical site infections? Treatment of surgical site infections follow standard principle of management of all surgical infection, which is the mainstay of treatment is source control or draining of the infected area. For a superficial surgical site infection, this involves opening the wound at the skin and subcutaneous level, take a wound swab for microscopic culture and sensitivity, commence broad spectrum antibiotics, and switch appropriately once culture and sensitivity result is obtained. Beta-lactamase inhibitors, for example, enhance the antimicrobial spectrum of an antibiotic, e.g., tazobactam added to ceftriaxone significantly reduces the minimal inhibitory concentration against ESBL-producing bacteria. Cleaning the wound along with dressing changes twice or thrice, 3 times a day is also helpful. Occasionally, sharp debridement to allow healing of the open wound is necessary. Once the wound infection has been controlled, then secondary wound closure is done. In some cases, vacuum-assisted closure is increasingly used in the management of large, complex open wounds, and this can be applied to wounds in locations that are difficult to manage with dressings. But I have to say, in our local settings here, these are not routinely available. This is an example of vacuum-assisted closure. For treatment of organ space infection, adequate source control is achieved by a drainage procedure, either open or percutaneous. For example, options for drainage of intra-abdominal abscesses include ultrasound-guided drainage or open approach, either transperitoneal or extraperitoneal drainage. How do we prevent surgical site infection? We can adopt preoperative measures. Patients should stop smoking. We should correct anemia. We should stop steroid, control diabetes, control comorbid condition, correct malnutrition, adequate burial preparation for patients that are going for colorectal surgery. Hair removal should be done only when necessary, preferably with clipper, not by shaving. Admit patient for elective surgery very close to the surgery within 24 to 48 hours. Treat remote infection before admitting patient for surgery. Proper theater design, including adequate ventilation and regular theater fumigation. Intraoperative measures, antibiotic prophylaxis should be given within 20 minutes of the surgery and should be repeated if the procedure will be prolonged. Adequate oxygenation is very important. We should maintain normal temperature, adequate glycemic control for diabetics, maintain normal volumia, proper scrubbing, proper gowning, proper donning of surgical gloves, proper skin preparation, proper draping, avoid using unsterilized instruments, gentle handling of tissues, among others, meticulous dissection, secure adequate hemostasis, use drain only when appropriate and necessary, proper anastomosis without tension, use of antimicrobial coated suture for wound closure, as we demonstrated in the Falcon trial, which we are awaiting our results. Post-operative measures include proper wound care. Ideally, each patient should have a separate dressing pack. We should also prolong the use of antibiotics as indicated. We should ensure the patient is well hydrated. Patients with dirty wounds should be nursed in separate cubicles from clean and clean contaminated wounds. Overcrowding of patients should be avoided. Proper nursing care and ensure overall patient cleanliness is important. We should remove them as soon as possible, and we should institute early nutrition. Because we have a short time, we couldn't go into critical details of this discussion, but by conclusion, I will say that surgical site infection is still a challenge in our practice, despite advancement in surgery, and measures at prevention will play a vital role in reducing the incidence. Thank you very much for listening.
Thank you
Thank
so
you
much,
very much for,
Dr. Patankar and Dr. Bala.
yes.
Yeah.
Thank you very much, sir.
So, Dr. Rahul, I have some more videos if you'd like me to share on peritonitis, if you would like that.
Sure, sir. Sure. Would like to. We already have started getting some requests for additional videos. If you have,
Sure.
yeah.
Able to see the videos? Are you able to see the video?
Not yet, doctor.
Okay, let me just try once again.
Dr. Pardon, you need to share your screen at first.
Is the video seen now?
Yeah, it's coming. Yeah, we can see it now.
So great. So I'm a little bit of expanded indication. This is a patient who came to us almost 48 hours after a perforation. X-ray abdomen showed free gas on a diaphragm, and you can see that there is considerable upper abdominal contamination. And I'm just going to show you a large perforation in the duodenum. Now, this is a point I made about how you can give a good lavage. Now, look at the amount of peritonitis this patient has. Clearly, it's a 48 to 72-hour-old perforation. But my take is you can actually do a better suturing and better lavage in these patients with laparoscopy as compared to open surgery. So initially, our anesthetists were unhappy about doing these patients, but they also realized that the post-operative morbidity, the respiratory problems are much lesser when you can manage these patients laparoscopically. This is a classic Graham's patch. I'm doing a suture and then I'm taking an extra bite of omentum. So the second layer is with omentum, and omental patch is put on the duodenum. In very sick people, we put a nasojejunal tube. Otherwise, I'm very sure this situation that the patient will not have a leakage in this situation. I'm now going to show you a perforated gallbladder. So this is a patient who you can see a biliary peritonitis following a perforated gallbladder. So all of these patients are going to present to you with surgical sepsis. The presentation is going to be tachycardia, tachypnea, gram-negative sepsis. In this patient, we had a CT scan which showed a gangrenous cholecystitis with patchy enhancement of the wall. You can see bile leaking from a perforated fundus and extensive peritonitis for this patient. What you need to do in this situation is use a lot of hydrodissection. Remember, the callous triangle will be quite frozen. Use a lot of water, use your suction device, and I tell my fellows and residents, the suction machine and the suction probe should be like the surgeon's index finger entering the abdomen. Here you can see the perforation in the Hartmann's pouch, and I'm gradually working my way, creating a window behind the gallbladder, and then separating this off and completing a cholecystectomy. But you should be ready in this situation of doing a subtotal cholecystectomy also. So like I said, it is standard practice in our department to do this. This is a patient who came with a ileocecal perforation. And you can see the bile and the typical ileal content coming. This is in fact another ileal perforation that came to us. Patient had fever for the last 5 days. He was being treated in a peripheral hospital with ceftriaxone and metronidazole, and we could see a large perforation. Remember, see the edge. The edge I'm unhappy about. There is severe enteritis of the bowel, so be careful of this. Do not try and close this primarily. It may be worthwhile for you to actually exteriorize this bowel using this. This is now a very interesting patient who came to us with a laparoscopic fundoplication done, and on day 4 he developed this perforative peritonitis. Why should an elective hiatus hernia surgery cause peritonitis? The CT showed a leak from the stomach and extensive contamination. Patient was in gram-negative sepsis 2. So what we did in this situation was we first give a good wash, and what you can see is the part of the stomach that's come from behind the esophagus has undergone a ischemic perforation. See the amount of contamination. See the amount of slough that is in the abdomen. So my take to you, ladies and gentlemen, is laparoscopically you can give as good or perhaps even a better lavage as compared to open surgery. The laparoscopic camera virtually allows you to go into the subphrenic area, the subhepatic area, the pelvis near the rectum, and it's as if the surgeon's eyes are going into the abdomen. What we done, this was clearly a ischemic perforation of the stomach. We closed the stomach perforation and then did a feeding jejunostomy for this patient. So this needs, you can either place a nasojejunal feed because these do have a small chance of leakage and enterocutaneous fistulas. So taking care of nutrition, remember these are surgically compromised patients. Look at the host patient. Look at whether he is sick, whether he's hypotensive, whether he's in sepsis, whether his hemoglobin is low, whether his albumin is low, and then make your decision based on the condition of the patient. And the most basic thing that you will find is a bad perforated appendix. Now, this was an elderly patient. Remember, appendicitis in people above 60 has significant morbidity. This patient was treated conservatively elsewhere, And you can see me laparoscopically doing a very almost like an appendicular lump had formed, lot of contamination of the abdomen. I'm using a combination of bipolar and monopolar cautery. I emphasize that you don't need harmonic scalpels and fancy gadgets. What you need is sound surgical principles and safe technique. And you can see me using a monopolar and bipolar cautery, taking care of the gangrenous appendicitis, evacuating all the pus that is in the abdomen. And in this patient, remember, I did not put in a drain. This is based on what we discussed earlier. If you have a bad local peritonitis, I do not see any reason to put in drains. If you have a generalized peritonitis, you have an enteric perforation, you have a due perforation, then you can put in a drain as we discussed. But so judiciously use drain, this is extremely important. Let's see what else I can show you. So this is a patient who came to us following a colonoscopic perforation. This is in the year 2012. My colleague, who is a gastroenterologist, was doing this. And the minute you will find that you could see free peritoneum there. And as he was coming out, he could actually see the liver. And this is the sign. When I'll rewind this video a little bit more carefully. When you're getting, you must be in the lumen of the intestine. We do a lot of endoscopic training in our hospital. This is fine. You are through the perforation and you're seeing omentum. This is a disaster. This is an injury at the rectosigmoid junction causing a fecal peritonitis. Very important, you find out on table. When you find out the perforation, remember this is a prepared bowel. There will be no contamination. So take out your scope, immediately take a consent of the patient, and then do a laparoscopic surgery to close the perforation. Generally, these patients do not need defunctioning stomas. So this is absolutely important and should be emphasized for all our youngsters. I will show you another due perf, just to emphasize that, bad contamination can, this is the pelvis. This is an old perforation. You see the amount of interloop adhesions, you see the amount of pus flakes. So I would give a 5 to 7 to 10 liter lavage. Another important thing is the normal saline that you put in the abdomen should be warm. Remember, the peritoneum has a big surface area. If you put in cold normal saline, you are causing hypothermia. And the patients tend to shiver. Remember, a shivering patient causes increase in cardiac output. And if your patient has a compromised cardiac function, then he is not going to do well. And we precipitate a cardiac crisis in somebody who's got borderline cardiac function. So you can see that there is extensive contamination. I'm giving a good wash. I make no effort to find the perforation. My funda is very clear. Unless you clean out the abdomen, unless you take out the pus, unless you take out the bowel content, the perforation closure is second. And here you can see a large perforation. And you can, at this point in time, decide, is simply a perforation closure good enough? Or do you need to put a omental patch? Would you like to do a laparoscopic feeding jejunostomy? Another option is to do a nasojejunal tube, because that will help to take care of the patient's nutrition in the post-operative period. So it is our policy in our hospital to routinely use this laparoscopic technique. And I hope that the videos have been to a large extent eye-opening for you. And I'm sure the youngsters in the audience must keep an open mind and use minimal access surgery liberally in managing the patients with source control and surgical sepsis. Thank you very much.
Thank you so much, Dr. Roy. There are some questions now. This webinar is going to be now. Currently, it is live webcasting is happening at multiple locations at different teaching hospitals, general hospitals in various countries. And I am getting some questions from the live audience here. So, Dr. Patankar, there is a question from Kaduna from Nigeria, from Dr. Stephen. I'm not sure whether you have already covered it in first video of lavage. And the question is, when doing a laparoscopic procedure for typhoid perforation, how do you ensure proper peritoneal lavage? And any video for that?
Yeah, Dr. Stephen, I did show you some videos, and as I mentioned to you, I use a lot of warm normal saline. It's important that you wash out the subphrenic area, the subhepatic area, the interloop abscesses, and the pelvis. because you often get collection in pouch of Douglas. I may leave the perforation closure to my surgical fellow, but the lavage I will do myself, because that is the most important part. And immediately on table, you will find the tachycardia coming down as the contamination coming down. So Dr. Stephen has made a very valid point that good lavage with adequate amount of warm normal saline is very, very important, Dr. Rahul.
Perfect. Thanks, Dr. Patlinkar. And there is one more question to you, Doctor. From this is from Federal Teaching Hospital from Ikiti from Nigeria. And Dr. Fatodini would like to know: will laparoscopic repair of typhoid perforation allow for adequate evaluation of the gut to make the best choice for the patient with simple repair, resection, and anastomosis or stoma?
Absolutely. These are extremely important points that you have brought up. The final decision depends on the operating surgeon. Look at the patient carefully. Look at your own surgical skill. Look at the infrastructure that you are working. Are you in a teaching hospital? Is it a tertiary care institution? Do you have good ICU backup? Do you have a good laparoscopic assistant? In the middle of the night, working with a single chip camera, you are better off doing a quick open surgery and doing damage control. If you're in a teaching hospital with good backups like I have, we have good intensive care, we have good anesthesia, 90% of the perforations in our center are done laparoscopically. The decision whether to do only a perforation closure or a resection anastomosis or doing a damage control by exteriorizing the perforation is something that the surgeon needs to make on table, looking at the condition of the patient and how much of sepsis there is and the nutrition of the patient. But these are very, very valid points that doctors brought up.
Right. Dr. Bala, can you hear us?
I hear you clearly and well.
Dr. Bala, you're on mute, I think.
Yeah,
Okay.
I think,
Yes.
yeah, we can hear you now. There is a question for you from Dr. Jacqueline.
Okay.
What are some of the do's and don'ts that a patient should be educated on or after surgery?
Okay. The do's. After surgery, there are some principles we have to take care of. Adequate wound care, good antibiotics with broad spectrum activities, also proper hydration. Patients should also be given analgesics for pain control. Then, as early as possible, when the boil sound returns, early nutrition. And the don't is, first of all, you should not use contaminated instruments in dressing the wounds. We should not use expired drugs. We should, as much as possible, ensure that we maintain surgical asepsis. These are the do's and don'ts. I hope you've heard me. Hello.
Loud and clear, Dr. Bala.
Fantastic, fantastic, fantastic.
Yeah. Thank you, Dr. Bala.
Thank you.
Next question is, I think both the speaker can attend this. How best can one manage typhoid perforation in rural settings with little or no post-operative equipment to improve outcomes?
Come again. If I should get you.
Okay, I will read the question. How best can one manage typhoid perforation in rural settings with little equipments available post-surgery?
Fantastic. In patients that have typhoid perforation in the rural setting, in this setting, most likely we may not have a competent anesthetist. We may not have facilities for ventilation. First of all, you should ensure that you correct potassium, but do not insist of absolute correction of potassium. So you give the patient anesthesia, you ensure you give the patient ketamine, but do not use mosorelaxant. Then the principle is that ensure you do proper peritoneal toileting. That is, you remove all the contaminants, do the repair, and copious lavage as much as possible, 8 to 10 liters of fluid. Then afterwards, post-op management, try as much as possible to give the patient the best antibiotics that is available in the environment. The best, but the most critical point is that please, we should avoid muscle relaxation in patients in the rural setting where we don't have a good anesthetic machine, where we don't have a competent anesthetist, where we may just make do with the anesthetic nurse, and we also ensure that we do proper lavaging. Thank you.
Dr. Patankar, your views, please, on
Yeah,
this
I
question.
think Dr. Bala has made some interesting comments, and I think I keep telling my residents it is horses for courses. Look at where you are, look at where your infrastructure is, look at how ill the patient is, and I would do what, as Dr. Bala said, is do damage control surgery. Intervene, good lavage, I would have a very high chance of doing a stoma or exteriorization of the perforation rather than closure because of the risk of post-operative leakage. It is better to do a second surgery on an alive patient than doing an excellent anastomosis on a leaked patient who dies post-op. So very carefully look at the patient and where you're operating, and that decision must be left there. But Dr. Bala has made some very appropriate comments.
Well, next question is from Dr. Folami. Pardon me for mispronunciation. Dr. Folami would like to know, Dr. Patankar, that what is the rate of ICU admission in patients with laparoscopy and open surgery?
So, Dr. Malik, I don't believe that. In fact, I think post-operatively respiratory problems are lesser with laparoscopy, even in septic patients or badly contaminated patients, because the atelectasis consolidations are much lesser in elderly people. We are basically a tertiary care institution. We get a lot of patients referred to us with old peritonitis, with enterocutaneous fistulas, with peritonitis who come late, who have many comorbidities and high risk factors. So our rate of hospital ICU admissions is much higher than what a smaller hospital in the periphery would be. But I don't think there is any difference between laparoscopy as well as open surgery. What is important is the host factor, the age, comorbidities, steroids, sepsis, and the amount of contamination. That will decide whether the patient goes in ICU or not. In fact, the laparoscopy is usually a shorter surgery. There is less post-op pain. The post-op breathing is better, and the post-op atelectasis is better.
Okay, there is one more question from Dr. Folami for you, sir. What can be done to improve laparoscopic skills in their teaching hospital?
Call me to Nigeria. I'll come and teach you. Or you can come to India. We'll be happy to train you here.
Right. So I think we should connect both of you separately, maybe after this program.
Sure.
I will move to next question. That what is the place of steroid in the management of sepsis?
So the surviving sepsis guidelines do actually mention the early use of peripheral doses of noradrenaline and use of steroids. But you must do this after sending off cultures, giving good antibiotic cover, as well as taking care of source control. These are only patients with severe sepsis that you would consider steroids, not in the early situation.
Okay.
Dr. Rahul, I also want to mention to the audience that we do run courses in upper GI and lower GI endoscopy, as well as advanced laparoscopic surgery, lap colorectal, as well as lap hernias. And if anyone would want to come here, please do connect with us, and we'll be happy to take this forward.
Fantastic, sir. We will also pass on this message separately. Yeah, with this, I will move to next question for Dr. Bala. When do we start managing sepsis?
Management of sepsis involves so many factors. In the surgical setting, sepsis control involves so many principles. First of all, we have to do what is called source control. In the case of abscess, we have to drain the abscess because use of antibiotics is not a substitute for draining of abscess, because antibiotics works better when the infection is at the cellulitic stage. Then one very important principle is that we must take culture for swab for culture, microscopy culture and sensitivity, and we should know the appropriate antibiotics to use for the patient. And we must look for the risk factors for that sepsis and control it. For example, a diabetic patient, that must be controlled. Otherwise, we are not going to win the battle. In summary, these are the basic principles: source control, proper antibiotics, wound culture and sensitivity, as well as identify the risk factors, and also maintain other issues like volume, fluid, analgesics, and so on and so forth. Thank you.
Thank you. Thank you, Dr. Bala. There is one more question, Dr. Patankar from Karuna, from Dr. Stephen. What are the strategies to reduce surgical site infections in a patient going for colonic surgery in an emergency situation that does not have sufficient time for bowel preparation?
So again, a very good question from Dr. Stephen. This we are talking of an emergency colonic surgery. So I presume somebody who has either a perforation or obstruction. Important thing here is to give good broad spectrum antibiotics at induction of surgery. During surgery, prevent or minimize contamination. Number 3, if you do contaminate, make sure you give extensive lavages. Number 4, collect appropriate cultures and do aerobic, anaerobic or fungal cultures as is suspected. And number 5 is local drainage. This should be the 5 principles that you follow in an emergent colonic surgery.
Right, Dr. Patankar. And I will move to, there is almost last question now for Dr. Bala about, as you mentioned briefly about the ESBL. So how severe is the problem of ESBL producing strains in Nigeria or in Africa region, and how big it is a concern for surgical side? Dr. Bala, you are not audible. Tejas, would you please look in Dr. Bala's audio connection? Tejas.
Uh-oh.
Yeah, we can hear you.
Okay, fantastic. I'm saying that extended spectrum beta lactamase organisms are a major issue in our country, and they account for a large chunk of infection, especially in surgical site infection, urinary tract infection, and pneumonia, among others. Now, especially in our environment, Escherichia coli as well as Klebsiella are very, very notorious in causing, as well as Pseudomonas are very notorious in causing infections. And one thing that I've observed that they do not really respond to most of the known basic antibiotics we have in our environment. So we need to often have to go higher and get very strong antibiotics, especially those that have combination, especially cephalosporins that are combined with tazobactam, for example, ceftriaxone tazobactam combination, as we commonly use in shalbactam TZ. It has been a drug that has been very effective in our environment, and in fact, in my hospital, it is a drug of choice in the management of surgical site infection, especially those with extended spectrum beta lactamase organism, as can be verified by various doctors who have used this product and are very, very happy and satisfied with it. Thank you.
Thank you so much. Thanks to both the speaker once again, Dr. Patankar, for taking our audience through range of surgical videos. I am sure it is going to help our audience to improvise their surgical techniques. Thanks to Dr. Bala for taking us through the basics of surgical site infection management from microbiology to prevention to the treatment side. And I would like to pass on our sincere thanks to the audience sitting at each location at all general and teaching hospitals across Africa, audience attending it individually from their respective locations through online portal. And last but the most important, I would like to pass on thanks to accrediting body like NMA for providing CME points for this program. So, audience, for this recorded video of this webinar, you will soon receive one email from our site where you will get link of the recorded video, which you can have a look in your free time. You can even circulate it to your colleagues, to your network, if they have missed to attend this program, live program. And not only this webinar, you will find recorded videos of all our previous 13 webinars at our corporate website. So stay tuned to our programs. Thank you so much once again.